Chinese name actually is Jia Jie Xu. Okay. And Professor Hui Na is the chair of the Collaborative Center of Integrative Medicine at the University of California, Los Angeles. Dr. Hui, a fellow of the American College of Physicians, is an internationally recognized scholar in internal medicine and clinical pharmacology. An expert in geriatrics, Dr. Hui has worked in NIH, FDA, and WHO, I think with a lot of experience. He is an honor professor and visiting professors in universities in China, Hong Kong, Korea, and Australia. Okay. His presentation title is "The Perspective on the Important Role of Integrative Chinese and Western Medicine in Global Healthcare." Yeah, Professor, please.
Thank you very much, Professor Liu, for your kind introduction. Well, Professor Topo talked about new medicine, and we have heard a lot about molecules, very exciting, research of stem cell. What I'm going to do is to kind of go back to the old medicine and go back to the patient. So these are patients that would come to us at UCLA. We are the clinic of last resort at UCLA. We have patients, this is a young patient, but we have patients going from the teens all the way to the 90s. And chronic disease, that's what we're talking about, chronic disease. These patients have all these problems. They don't come in with one. They come with many, many diseases. So where do you really begin to try to think about solving these type of problems? Okay? I'm sure as physicians, we all see medicine in our clinic. But when you go to the lab, it's a little different thing. Anyway, let's go back to William Osler. That the study of medicine begins with the patient, comes with the patient, and ends with the patient. And that is much more important to know what sort of a patient has a disease and what sort of disease. So actually, we have many, many diseases in the patient. In Western medicine, we have a problem list with many, many, many diseases. So how do you go about, approaching it? And obviously, this patient was referred to me by one of her 13 subspecialists. So I've been in UCLA 42 years. I've trained in chemistry, medicine, internal medicine, clinical pharmacology, geriatrics, and done bench research, developed a couple of drugs, taught clinical pharma for 13 years. And using basically sort of clinical pharmacology, internal and geriatrics to integrate Western medicine, at the same time trying to understand how Chinese medicine, for thousands of years, approach health and disease, and in what way the two can be put together. So it took me the first 22 years to figure out how to do it. In 1993, I established the Center for East Western at UCLA. And our goal is to try to improve healthcare that is safe, effective, affordable, and accessible for people, families, and communities. So my mentor, Dean Menonco, he's 90 years old now, and he has been an inspiration for me. And basically, I've given his tutorage for the last 30-some years. And this is something that he wrote for me actually in 1993 or 4, I can't remember. Because he basically emphasized that it's not just medical education, research, but cost-effective and compassionate care of patients, prevention of diseases, and also synergistic application of principles originating in Eastern and Western civilization. Okay, so that's basically what has been motivating me to try to figure out how to develop this type of program at UCLA. And obviously, we can't do it alone. We learn from actually many people, many experts globally, particularly many of the pioneers in China. China's been doing integration for the last 55 years. And we have been actually able to interview many of these pioneers. And if you are interested, explore im.ucla.edu is our web portal to actually we've interviewed Toyoyo, who just got the Lasco Award, for the discovery of artemisinin. Anyway, I'm going to talk about the clinical programs because I think this is a clinical model that I think would be sort of I can't patent it. I can only disseminate it to help patients. So at UCLA, we have many, many programs under a fabric of collaborative extensive integrative medicine. I'm the chair for the last 5 years. And in a month, 50 medical centers, including all the many UCs, Stanford, Harvard, Johns Hopkins Mayo Clinic, they all would convene at UCLA for our annual meeting. So this is our clinical model. We have board certified, most of the people are trained at UCLA, Stanford, Yale, Johns Hopkins. We have board certified internists who also know Chinese medicine, rather than just people with MD, PhD, MD, MBA, MD, JD, but basically people with MD, internalists, but also have Chinese medicine degrees. Okay, so we basically have also occupants who are trained in 2 years fellowship integrated medicine. So we now have about, for China, it's a very small number. We have 13,000 patient visits a year, and primarily the patients are referred by many of the faculty at UCLA. When they don't know what to do, they send it to us. So it has become my clinical laboratory to try to test out how this model may work, because most of these patients already fail evidence-based medicine. They already fail or intolerant of very strong medications or surgery. And so what I think we have is, using one model of medicine to look at the diseases, and then we use another way of Chinese medicine to look at the whole system, the whole pattern. And by using a flip shape, by going back and forth, we have more tools to have more conceptual framework, but also more tools technically to try to help the patient. So they can come in with all the different diagnoses, but we focus on the patient. Who is this patient? Why is this patient coming to us at this point in time? What happened to them? You look at the history very carefully. I mean, most of these people have been worked up. We try not to do the workups because most of these have been worked up, either UCLA, they've gone to Mayo Clinic, they've come, to us oftentimes because they're local. And the key thing is to try to understand them, as a person. Many people basically, even in utero, but basically as a child experiences, many sort of adult diseases, the seeds of ill health are planted in childhood. And that patient with many problems, she's a tough childhood. And that to me basically led to many of the problems, that I believe, unless we address it, it's not going to be, and then I understand the person's work environment, the psychosocial situation, trauma, even many minor trauma, especially now in China with all the traffic problems, car accidents, Parkinson's disease. I've seen a lot of people, neck and shoulder pain, many of them before they develop Parkinson's or even dementia. But I will talk about that a little later on. So nutritional, not the average standard nutrition, but the nutritional approach for a particular constitution. The kind of more or less nutrigenomics, nutrigenetics, okay? But then we try to at least talk to the patient, touch the patient. Touching the patient is very important for us in this clinic. Now, obviously, both medicines, both Chinese and Western medicine, get a history, and oftentimes we use the way to kind of weave together diseases, but also the pattern diagnosis. But Chinese basically use the pattern diagnosis to look at, what is the pathophysiology of the whole patient. Really don't have enough time to really go into that. I talk about 3,000 years of Chinese medicine in about 10 minutes. But basically, the pattern diagnosis is basically the signals that constitute the numerous pathophysical patterns that progress through set patterns of change, evolving into different genes as the patient condition changes in either positive or negative direction. So you look at all the history, and then it doesn't really matter what type of symptoms and also diseases. What I often try to find out is that where is the imbalance? We talk about balance, autonomic, neuroendocrine, immunologic, vascular, clotting, oncologic. So we talk about balance, right? And then flow. We talk about flow. Flow, obviously, we talk about flow of blood. The big vessels is the microcirculation, but I would say neurotransmission. So depletion is basically, they already get so depleted. But by the time they have chronic diseases, they already basically have low homocyte reserves to adapt to the stress. Okay. So that's why what we try to do, after we understand the person, we emphasize the importance of balance. Lifestyle contributes to 70% of the chronic diseases that we have. So how lack of balance leads to depletion. So we try to look at the patient's exercise routine, how they sleep, what do they eat, and for Americans in general, if they cut down the dairy, if they have much less simple sugar, they already got a lot better. Then we teach patients to do self-massage. A lot of the areas that you feel achy and having problems, when you go get your massage, you say those areas are acupuncture points. Okay, those are the acupuncture areas that need to be stimulated. Stress management is very important. I will reintroduce you to Bruce McEwen's research the last 15, 20 years in Rockefeller. But anyway, these are some of the things that we do. But it's not as important just the tools of treatment, but realistically try to understand the person. So the brain, unfortunately, internal medicine, and I talked to my chiefs, we don't do anything about the head. We need to understand the neuroscience, which I think is also moving very quickly. Mental health is such an important area. So the brain is the ultimate regulator of the entire organism. And Bruce McEwen, I think that his work, I think when he first published his work, actually in a nice review in New England Journal, he introduced the idea of allostatic load. And you can see that over time, when the load accumulates, and then the body just have overexposure to mediators of neural, endocrine, and immune stress that have adverse effects on various organ systems. So basically, preventive medicine is to try to look at the patient early on when they have autonomic dysregulation. I can see people smoldering from autonomic to immunologic before they get full-blown lupus. You can see it, you have to treat it. So primary care is very important. That's what I'm going to talk about, is that this work has to take it to the primary care for people to detect this early and try to reverse it early. Otherwise, it's going to take so much time for us to treat. Anyway, this is not a very good slide, but basically, when you have stress, you have a lot of bad clinical parameters. So, obviously, in the United States, over the last 20 years, there is a renaissance of complementary alternative medicine. And acupuncture is one of the areas that has become more mainstream. Herbal medicine is not, but herbal medicine, I think, is going to be very important. Toyo Yo's work is still the old model of finding new drug from the Chinese herbal pharmacopoeia, just like when I first went to UCLA was the ephedrine from Ma Wang. But obviously, there's a lot of things that one can do, with simply, stimulating the body. It doesn't have to be a needle. You can use it by your hand, and or laser, or magnet, or ball transfer. That's what we do. I mean, there are a lot of research over the last 40 years. Professor Han Jisung and also Chao Xiaoding from Shanghai, they've done a lot of work. But at Mass General, they just look at stimulating this point in the hand, and they tone down the limbic system. So basically, one of the things that we do for every patient is to teach them how to do stimulation of the Heku point, okay? And that also we have the patient try to participate in a lot of the body-mind exercises, whether it's mindfulness meditation, Tai Chi, yoga. There's a lot of research now that has been coming out in the English literature for the last 15, 20 years in good journals. JACS for prevent old people with falls, and also recently at UCLA published a paper on looking at Tai Chi, to help patients with depression. So prevention, I mean, obviously, Salk Institute, vaccine prevention is very important. Obviously, the Chinese agree that prevention is very important as well. And I would like to say a few words about prevention from the perspective of the continuum, because obviously, a lot of people, basically, they think they are not sick, but they're not well. Many people, basically, if I talk to them, they already have a lot of the so-called functional syndromes, and you basically can try to prevent many of the problems from going to so-called pre-disease, all the way to uncomplicated diseases. And I would say that Western medicine is actually very good in acute crisis intervention. We're very good in saving lives, we're very good in replacing, but right now we are blocking and stimulating. Instead, we need to go back to re-regulating the system. So the reason why we are in the midst of a healthcare crisis is because there has been a change, right, from acute to chronic, and most of our energy and money has been focused on the hospital-based acute crisis care. Even through the last 40, 50 years, there has been sort of emphasis, at least in some areas, prevention, wellness, primary care, but the incentive, the money has not followed. So it has not been successful. So now, this morning you heard about PricewaterhouseCoopers, but this one I read 2 years ago, HealthCast 2020. This was published in 2005. The current health system of nations around the world will be unsustainable if unchanged over the next 15 years. Increasing demand, rising costs, and uneven quality, misaligned incentives, overwhelmed health systems, creating massive financial burdens for individual countries and devastating health problems for the individuals who live in them. And that's the reason why the urgency now is to train more people who are now ready to try to carry out the healthcare reform. So primary care is important, but primary care to me is not just the physicians or nurse practitioners, but really primary care would be brought actually to the home. And I think that a lot of the information should be now made available, and that so these are some of the attempts for the U.S. government to try to see what we can do, because it's not just a healthcare issue. It affects the U.S. economy, and because of the economic crisis, it may lead to social crisis as well. So we've been working with China. I've learned from many of my friends, Beijing, Shanghai, and Guangzhou, and so when Wang Guoqiang came, Vice Minister came, we had a long discussion over a day, and also this is Fu Youyou when we interviewed her about 3 years ago, and I hope that she now has a very nice office and a good lab for her to do her work, because she really is a remarkable person. And, you can look at the web portal and have her describe how she led to the discovery of this very important compound that led to the Lasker Award. So China has been now promoting Chinese medicine and integrative medicine in the community health centers, and that try to also prevent pre-disease to all A-level TCM hospitals. And in Shanghai, which I was in April in the international conference, I kind of talk about the important role of integrative medicine in healthcare reform, but very importantly is to try to look at how you redesign the health system, how do you give incentive, and also to train a new group of clinicians to allow them to have enhanced ability to solve most problems. Because in this country, as I see it, primary care with the best Western medicine, we are not able to solve many common problems encountered in, so a lot of our patients actually go out of the current biomedical system to see other practitioners. And what we would like to do is to see how the two can be put together, with the AMCs leading, the way. And so prevention, I think, we really can, some of these will be addressed, like activities, diet, smoking cessation, radiation screening, but chronic disease management. I think the U.S. have done, a lot of work, with Dr. Wenner, and I think it's kind of important for us to look at the evidence-based approach and focusing on those contributing to the majority of health expenditure, and guidelines needs to be developed for prevention, treatment, self-management, and continuous monitoring. And personal training. I hope to be able to, and I train as many as I can at UCLA, but I hope to collaborate with other countries to enlarge the integrative medicine workforce. And I wrote a paper for China, actually, in the Chinese Journal of Integrative Medicine in January, with the idea that Western medicine needs to learn what would be useful as you develop primary care in China, what integrative medicine knowledge TCM should be plugged into the Western medicine training, but also for the TCM trained physicians. Many of them already, I think, have some Western medicine training, and they basically have some tools to help many of the early diseases. And I think that they would become very good primary care sort of team members. these are my dreams for a better global health model. It's not just medicine that we have to deal with. We have to develop an optimal healing environment. We need to basically have a good natural environment, with less pollution. We need to have places where people can walk, and we need to have people that have good healing relationships. When a lot of people under a lot of stress, doesn't matter what medicine you develop, it's still going to be symptom management and not really going to be as useful. And that we need to redistribute resources and provide right incentives to shift from the high-tech, invasive crisis intervention to low-tech, low-cost prevention and early disease recognition. And we need to integrate the best aspects of all appropriate preventative, diagnostic, and therapeutic approaches of different healing traditions, and ensure that not only the clinical, but also the behavioral, social, spiritual, environmental, and nutritional factors are included in the care and the delivery process. And seamless integration across health professions of different healing traditions. Now, that's a tough part. And UCLA, many other integrated centers in the United States, they may have different type of healing traditions. It's tough for me to even integrate Western medicine with just Chinese medicine, because the different language and to try to put together is not easy. So I think we affirm the importance of between practitioner and patient-based trust and respect. I understand that China has been under some concern in terms of patients, and this country too, in terms of trust and respect, as well as the importance of not only technical competence, but also compassion. So we have been actually sharing what we have learned the last 18 years with different level of trainees, all the way to people in the community. We train undergraduate and graduate students, and also medical students from all over the world. But we also train physicians and nurse practitioners, and we really think that the way to really have the most impact will be train more primary care clinicians. And we also take this away just from the medical field, but to people in communication and media, business and law, because you need to have the right kind of policy, right kind of economic model, business model, and computer science, and also anthropologists and sociologists. So this is my concluding slide, that while we continue to try to do our part as physicians in the clinic and do our research, as scientists, some of this information is already out there. We need to collate them, and that's why I'm also trying to get some of the beautiful work that's been done in China translated into English for people who are not able to access that information. And because I really think that for us to have an effective, affordable, safe, and accessible health system to meet public and patient health needs, we need to go back to people-centered public health and also person-centered clinical care, and that we all have to work together in collaboration. Thank you very much for your attention. I know it's very
thank you, Professor Hu. Very interesting. Integration, congregate, combination. In Chinese traditional medicine and Western medicine.
The integration is not international buffet. Okay? International buffet. I think what we have created is a gourmet dinner with different best ingredients in a nice environment.
Okay. Thank you. Questions, please.
So I was at UCLA from 80 to 93 in the engineering faculty, so we overlap but don't know each other. And one of the things I noticed happening, because I was in engineering and applied science, UCLA changed its business model to be more like David Chin described this morning. They went to scale. And they never really got into a financial crisis because of it. One of the things that they developed was UCLA community hospitals and community sites all over west part of LA, South Bay, and so on. Did they deliver the personal kind of care and start to approach when they built out the clinical side? It wasn't a big hospital now, it was where patients actually went. Did they take some of the things you have learned and distribute it throughout the LA basin as they did their economic model, which they did very effectively? How did your part work?
Well, basically, I mean, actually that's what I talked to the Chairman of Medicine just last Friday, because UCLA actually now, even though this is the best in the West Coast for the last 21 years, has probably only about 120,000 people's lives that they cover. UCLA, has to expand to about 2-3 million people to build a health system, and they need to build primary care very rapidly. And my proposal is that let's turn what we have learned and help many of the primary care physicians, to have, at least awareness. Not necessarily actually to do it, but to have awareness to be an important, leader in this new, collaborative healthcare team.
Yeah, could you tell us what is the major barrier to combine Western medicine and Chinese traditional medicine? What is the major barrier, and what's the solution to overcome?
Well, major barrier at what level? Clinical level, or at a UCLA type of institutional level? I mean, there are different type of challenges and barriers. I mean, when I first started, without Dean Mellenhoff, who was the dean for 25 years at UCLA, to become one of the world's major institutions, it was very challenging. Okay, so that's challenging, is to basically try to introduce Chinese medicine in a place like UCLA. Okay, but then you also have the financial aspect of it. Our model is saving. Okay, that's why this is my time. I mean, we save so much money that the HMO want to send as many patients to us, because one patient go to the emergency room, one patient in the hospital, so much money. So we have to survive financially. We have to make sure that legally we don't get into trouble. There's also social peer pressure problems. So and then how do you do it with the UCLA system, the charting? That's why everyone who comes through, they've gone through a fellowship with us, so that they really know what how to do it right. I mean, just that I've been at UCLA that many years. I mean, I sort of know how to sort of work with the system. But I don't know about other places would be challenging, because even in Hong Kong, Hong Kong, they have Chinese medicine and then Western medicine. But to do both, you need to know both really well. You know when to use what, and you don't want to get into any trouble.
Thank you. I'm from Beijing Hospital. I have a question. What kind of support you can get from the U.S. government? And do you have any suggestion for us, for the Chinese government to support more on this new specialty? Thank you.
Well, I think that the U.S. government right now trying to do comparative effectiveness research, outcomes research. I think some of these money will come. NCAM has been around for a good number of years, but I still that we need to go into whole systems research. We need to go to some of these other new research approach. In terms of clinical care, the U.S. government, Medicare does not pay for even acupuncture. But many insurance companies are beginning to pay for acupuncture, but pay for such a small amount. I mean, it's more or less, as I said, a cost-saving approach. So I'm just talking about revenue, which is very important. But China now, the government is very interested, in building integrated medicine and Chinese medicine. But I think that most of you are from Western medical schools, and I think it's very important that the schools take a leadership role in trying to look at integrated medicine, and as you build primary care, try to, I would happy to collaborate to try to see how to get the primary care physicians, I'm not talking about people, I'm talking about people who are, board certified internists, family medicine, geriatrics. I mean, those are, the faculty that I think, need to be developed, and also, but much more in terms of like, because right now there's so many specialists, so many, procedures, and then you have patients who do not have, a person, or actually right now in the U.S. we call the medical home. so that anyone who get a problem, they know where to go and get everything that they want from the medical system.
Okay, last question.
Sorry.
It's an interesting subject, but it's also a very difficult subject. Why I should say, because when I was working in WHO, once when WHO have a financing crisis, they said what kind of program should be set down as they discuss as the sunset program. One of the subjects is traditional medicine. So they wanted to cut this traditional medicine, but at that time I'm the Assistant Director General in charge of traditional medicine. So I tried to protect it. And I organized a meeting, discussed with 6 Assistant Director General. I said, give me the reason why traditional medicine should be abolished. But after discuss for 2 weeks, it was survival. And I said, the only thing is we want all the people knows the traditional medicine has really contributed a lot to the human health. And also Germany, Japan, and many member states, they are, of course, China and Korea too. But on the other side, the traditional medicine, the terminology is also very difficult because I'm now served as an international bioethics committee in the UNESCO now. And one of the subjects is what is the ethics issues in the traditional medicine. Then we ask all the member states. They have so many traditional medicine, the India one, the Africa one, the South American one. They also give a lot of spiritual kind of treatment. They also consider that as a traditional medicine. So we come to a very difficult subject now. This is an unsolved question. Still we are working in UNESCO. So I would like to see how you define the traditional medicine. Some of those traditional medicine for the Chinese, we don't think it is called traditional medicine. We call this magic, you know. But this magic is also can treat some psychological patients. So how to define this? Thanks. This is the question, maybe no need to answer, but I wanted to throw it out for you to consider this very interesting subject.
Oh, thank you for your very meaningful comments and suggestions. Okay, sincere thanks to our 5 speakers.
Thank you very much, Chair.